Right, well, good evening, good morning, good afternoon. Welcome to another ISUP Presents. Today, Arno van Leenders is going to talk to us about radical prostatectomies. Can I ask that if you ask any questions, you do it through the Q&A and not through the chat function of Zoom. You'll see that on the bottom or the top of your thing. So please ask your questions through the Q&A. And well, let's get started. It is just 6 o'clock. So Arno is a GU pathologist at Erasmus MC in Rotterdam in the Netherlands, and his main interest is the clinical and three-dimensional and molecular biological relevance of prostate cancer growth patterns. He's also the European counsellor for ISUP and the case of the month manager. So if you have a case you think is good for the case of the month, then please drop him an email, and please do have a go at the case of the month. They are sometimes stretching, but when you actually get the right answer, it is brings you a bit of pride to your abilities. So let's move on. So over to you, Arno.
So thank you very much, John, for this kind introduction. I'm still sorry for Sunday evening, but life goes on. So I would like to welcome everybody on this ISUP webinar on radical prostatectomy assessment, anno 2021. Let's see. Yeah, I do not have any conflicts of interest for this presentation, and if you have any questions, you can ask them by the website using this Q&A logo, and do not use the chat. So radical prostatectomy has been the major treatment for patients with low and intermediate risk prostate cancer over the years. But last year's treatment indications have changed, as can be seen in this picture. So what you can see is that when earlier days, many people with low risk disease got radical prostatectomies, nowadays this number is declining. So patients with very low risk and even favorable intermediate risk prostate cancer do not undergo radical prostatectomy anymore, that more common, but they are more often, of course, offered active surveillance. What we can see is that the number of radical prostatectomies in unfavorable intermediate risk disease and high risk disease is increasing. But if you look at these figures, it's always important to always realize these are often data from nationwide study, and that do not always represent what's going on in your own hospital. And just to give an example of what we did in the Netherlands, so we just looked how patients were treated that were diagnosed with very low risk prostate cancer on biopsy. Of course, most of these patients would have to undergo just active surveillance, but no active treatment. But if you look in this small country of the Netherlands with only 28 hospitals included in the study, you can see some include almost all patients in active surveillance, but you can also see that there are quite some hospitals that still would operate 20 up to 30% of patients that have very low risk prostate cancer. So what does that mean? So that means first that there is some room maybe for improvement. Maybe patients would do better if these hospitals would start offering active surveillance. But it also means that not always the data from every hospital is comparable. So if you would compare this hospital with that one, probably here more intermediate risk, high risk patients would be operated, and here would be more low risk patients. So you cannot really compare the patients being operated in this and that hospital. So it's always important to be aware for your own institute, what are the figures? Where are you on this kind of graphs? Okay, then I will talk a little bit about grossing. I'm not going too much into detail. I'm sure you're doing a very good job already in your own institute, but just a few selected issues. Well, as we know, prostates can really have different sizes. They can vary in shape from a walnut to an apple. More scientifically, they can have a weight of about 20 grams. That's usually in young men, or when you're old and have huge BPH, more than 120 grams. So you can really see this in daily practice. What's the consequence? What's the clinical relevance of that? Well, first you should know that if you have a very large prostate, for the urologist, it's more difficult to get the prostate out. So surgically, it's more challenging. And what's actually interesting, that when you have this huge prostates of over 100 grams, often you can only see they only have very small tumors with very good outcome. So actually, there are some studies out there that show that the smaller prostates often have more aggressive tumors than the large ones. Okay, this is about weight of a prostate size. But if you really look carefully on your radical prostatectomy session, you can also see there's a difference in shape. And I'm sorry, I do not have pathology pictures of this, but if you carefully look, and there has been a very nice imaging study on that, you can see prostates have different shapes. Here you can see this patient here, A, has more a pyramid-like shape. You can see it very nice here. On the other way around, there are patients that have more a round apex, looking like this. Patients that are ventrally deeper going and posteriorly deeper going. So what does this mean? Well, if you look in your radical prostatectomy, sometimes you can see that. So here is the apex more a pyramid shape, here it is more round. In this case, the apex goes a little bit into the pelvic floor muscles. So if the urologist wants to cut out the prostate, he also has to sacrifice part of the pelvic floor. And pelvic floor, of course, is important for continence after operation. So if you cut out the prostate like this, you would have higher chance of urinary incontinence after the operation. From the other side, if you have this prostate, this is more a round apex that is more laying on top of the pelvic floor. And the urologist can really section this out with only minimal damage to the pelvic floor. And these patients often have better continent function after operation. So some studies also show that mainly these kind of shapes are called apex Lee types, according to the person who first described them. And specifically, apex Lee shapes C and D have better functional outcome. So less incontinence after the operation. But the other side of the coin is that the apex C side more often have positive surgical margins at the apex. So it's just of interest that you can see these differences in size and shape of the prostate and what they might mean to you. When we get radical prostatectomy, it's not always only prostate tissue we'll see. But we can often also see fat tissue around the prostate. Well, why is that? Well, within the fat tissue around the prostate, and specifically at the posterolateral side, contains blood vessels, but also nerve bundles. And these nerve bundles, they are important for regulating continence and erectile function. Of course, you do not want to sacrifice those nerve fibers, because that will mean that the patient has a higher risk of erectile dysfunction and high risk of urinary incontinence after operation. So the urologists want to save these nerves, and that's called nerve-saving surgery. Well, the level that the urologist is doing this is variable per site and per operation specimen. So urologists can take out all the fat tissue on the site of the radical prostatectomy. So that would be minimal nerve sparing. And that's actually what you can see at grossing. So here you have just the outer side of the prostate, but you can here see this chunk of fat tissue. And this corresponds to a non-nerve sparing or minimal nerve sparing operation on this left side. On the right side here, you can see there's also a little bit of fat tissue, but it's much less than here. So the right side here was operated in a partial nerve sparing way. So you can see this difference between specimens and even between the left and the right sides. And we will go back later to that when we discuss surgical margins. What's the meaning and the relevance of saving the neurovascular bundles? But you can appreciate this during grossing. So then a few words on how to sample that. I think most people, most laboratories, when they have a radical prostatectomy, they will include all the slides, so all the tissues just like that, so complete sampling. And why is that? That's of course because it's very difficult at grossing to distinguish tumor and normal tissue. So that's why we include all the tissue. But is this the only way? Well, several studies have looked at that if you do a kind of partial sampling, so what are the results? How much will we miss? Well, there has been a very nice study in 2013 that looked at different ways of sampling radical prostatectomies, and these are the outcomes. So using this methodology, where they have one slice in, one out, one in, going like this, at 28% of the extraprostatic extension was missed and 13% of the positive surgical margin, so quite a bit. Well, even when they included even less, so one side in, but only the dorsal part, then one side completely out, then one in, but the ventral side out. In this way, even more extraprostatic extension was missed, 47% and 21 positive surgical margins. But you could also use a more smart technique and for instance, always include the dorsal side. Of course, we see on a daily basis that radical prostatectomies mostly have the tumors at the dorsal side. If you include those only, and then for instance, one slide in the middle, you only miss 7% of extraprostatic extension and 5% of positive surgical margins. But there are more flavors here. For instance, if you would find a tumor here extending to the ventral side, you could go back and also include at second term this or that part. You could also get information in of which biopsies were positive. For instance, were only the right side positive biopsies positive and the neck one's all negative, or what were the MRI findings. So these could all help in what technique you could use. So in 2009, in the ISUP Consensus Conference on Handling of Radical Prostatectomy, this was extensively discussed, and it was then determined that partial sampling is acceptable. And in case of partial sampling, it's important to use a very specific protocol, describe this protocol, and always use the same. So do not change every radical prostatectomy. And as we've just seen, so if you include, for instance, always the dorsal side, and maybe just based on your findings from the dorsal side, also some ventral sides, you will only miss only few cases of extraprostatic extension and positive surgical margin. So the clinical impact probably will be very limited. But we should be aware of two other points if you do not perform complete sampling. Because of course, we all have these regional and nationwide quality assessments, and it's very difficult to interpret those quality assessments if one lab is always do complete sampling and another one a partial sampling and another one a partial sampling another way. So it's very difficult to compare the results between the centers in them. Another argument against partial sampling is that your material will be much less reliable for research purposes. So if you want to do research, I would not advise you to do partial sampling of the radical prostatectomy because your data will not be generalizable. Okay, then the microscopic evaluation, and we start with grading. So before I go into detail in the prostate cancer grading, I just want to refer to this international collaboration on cancer reporting. The ICCR website really includes very good radical prostatectomy sampling and reporting schemes, putting in required and recommended data. And what they require is, of course, that you put in the histological type of prostate cancer. Mostly that's acinar adenocarcinoma, might also be ductal adenocarcinoma. Grade, information on extraprostatic extension, seminal vesicle invasion, and surgical margin status. So I will start off now with grade. Of course, we are all very much aware of the importance of tumor grading and clinical outcome. And we've all seen these figures, but I want to draw your attention specifically to the outcome of patients with Gleason score 6 at radical prostatectomy. So in this study of more than 1,000 patients, you can see here this is a very horizontal line, meaning that during follow-up, none of the patients with Gleason score 6 at radical prostatectomy developed metastasis or died of disease. They will have 10% about biochemical recurrence, but they will not metastasize or die. And this was also found by other groups. So for instance, this publication of Ross from Johns Hopkins Hospital included more than 10,000 radical prostatectomies and did not find one single metastasis of a patient with Gleason score 6 cancer. This other study from Leo included even more radical prostatectomies and found a very low percentage of metastasis, but one has to say that they did not go back to the slides that metastasized. So maybe these were just patients that would now be graded Gleason score 7 based on the ISUP 2014 grading schemes. So that's what's important to realize, that if you say a patient has radical prostatectomy with a Gleason score 6, that actually you say this patient will never metastasize or die of the disease, though biochemical recurrence might occur in 10 up to 15% of cases. So in 2009, the ISUP held its latest conference on reporting of tumor grade, and I will just summarize the most important data for radical prostatectomies. Well, first is to always report Gleason score in conjunction with grade group. Specifically, urologists like grade group because grade group 1 and 2 sounds much better than Gleason score 6 or 7. Second, in case of multifocality, report a tumor grade for the patient for the tumor with the highest grade, the largest volume, and the highest stage. As we are all aware, multifocal tumors occur very common in radical prostatectomies. You can see 2 up to 7 tumors in one radical prostatectomy. Mostly you will have one dominant tumor that has the highest volume, the highest grade, and the highest stage. In some occasions, you might have, for instance, a large Gleason score 6 tumor in a transition zone, but a smaller Gleason score 7 tumor on the dorsal side that is going into the fat tissue, which would then PT3. So in that case, you would grade both of them separately. You do not have to grade each tiny small tumor you can find. Further in the ISUP meeting, we determined that we do not grade minor patterns, and that's defined at less than 5% of the tumor volume of higher patterns. So if you had to have a tumor with 97% grade 3 and 3% pattern 5, you would call this 3 plus 3 is 6 with tertiary component 5, and not 3 plus 5 is 8. So this is different from a biopsy. So in a biopsy, if you would have 97% 3 and 3, 5, you would say the most common, that's 3, and the highest is 5, no matter what its percentage is. So in biopsies, this would be 3 plus 5 is 8. In radical prostatectomies, we need a cutoff of at least 5%. So this was 6 with tertiary pattern 5. It's optional to include the percentage of grade pattern 4 and pattern 5. It's important to always include presence of invasive cribriform and intraductal carcinoma. And what is also discussed is that intraductal carcinoma mixed with invasive carcinoma can just be graded as if it were invasive tumor. So you do not have to do extensive immunohistochemical stainings to distinguish intraductal carcinoma from invasive cribriform carcinoma. Just grade it as if it were invasive tumor. Well, I know this latest rule has raised quite some debate whether this is a good rule, yes or no. ISUP has determined that this is really acceptable and it's very more practical. Specifically, it's important for biopsies. So patients with a Gleason score 6 tumor on a biopsy with intraductal carcinoma, all pathologists agree this is an aggressive tumor that should not be taken into account for active surveillance, but should actively be treated. Well, ISUP now says just to notify that extra to the urologist, we would just not label it as 3 plus 3 is 6 plus and intraductal carcinoma, put with just now grade intraductal carcinoma, and then you would have 3 + 4 is 7 with intraductal carcinoma. So this is giving more attention to the urologist. That is an aggressive tumor that should not be put on active surveillance. So how many patients change by Gleason score by grading intraductal carcinoma? That's just a small subset. Well, the first to report on that was the group from Ireland, and they looked at more than 2,000 biopsies and found that 123 of them had intraductal carcinoma. Of these 123 cases, 28 changed their Gleason score if IDC was graded. So that was 22%. So this might seem quite a bit, but if you realize what it is on the total population, the grading of intraductal carcinoma overall will only change the grade and biopsy of about 1%. Similar study is what we did, and about 1,000 biopsies had higher percentages of intraductal carcinoma, 12% grade change, but overall 1.6% of all the biopsies had a change of Gleason grade if IDC were graded. And then in radical prostatectomies, the figures are even more limited. So intraductal carcinoma, if you grade intraductal carcinoma, you'll have a change in grade in 5 of these tumors. That would even be less than 1%. So IDC grading, lots of people discuss about it, and it really has impact, I think, for patients with Gleason score 6 with intraductal carcinoma. Just to notice to the urologist to not put those patients on surveillance. But if you look really on all your biopsies or radical prostatectomies, this will lead to an overall change in grade group only in about 1% of cases. So impact of grading is limited. Only a few patients will change the grade. And just to compare with it, if we just look at standard intra-observer studies, you will have only about 20 up to 30% variability in tumor grading only because another pathologist is looking at it. So that is much more and has much higher clinical impact than grading intraductal carcinoma, yes or no. So a few more conclusions. So we just discussed that percentage grade 4 has additive value in risk prediction at radical prostatectomy, but its inclusion in reports is just optional. It's not required. Invasive cribriform and intraductal carcinoma has important value in outcome and tertiary pattern 5. So if you look at these figures, and these are all from radical prostatectomy specimens, you could ask the questions, are these really independent? Or is it that patients with higher percentage grade 4 also have more common intraductal carcinoma or cribriform carcinoma and tertiary pattern 5? Well, actually, that seems to be the case. So if you have a higher percentage grade 4, you tend to have more common tertiary pattern 5 and also more common cribriform carcinoma. If you put all of these 3 parameters in multivariable analysis, only cribriform intraductal carcinoma stands out. So that seems to be the most important factor to include in your pathology reports. Then staging. If you're going to stage prostate cancer, it's already important which book are you going to open. If you open this book of the UICC, you will see PT2 is staged as PT2A, B, and C. However, if you use the American manual, you can see there is only PT2. And I think very unfortunate that there is no alignment between these staging systems, and that they are not exactly the same. So just go a little bit into detail. Is this useful to use a subclassification? So PT2A is defined as 1/2 of one lobe or less, PT2B more than 1/2 of one lobe but not both lobes, and 2C both lobes. So this would typically be a PT2A tumor, just one lobe and less than 1/2. But this small tumor in the midline involves both lobes, the right and left one. We would call this, according to this definition, PT2C, but intuitively, probably this will behave much better than this one. And how to grade multifocal tumors? We know they are very common. Should we grade them purely by this definition and say, oh, that's tumor involving both lobes, so that's 2C, or say, no, there's two multifocal tumors, both being 2A. Yes, that's not really sure. But that's not the whole story. Because if you look on how often do you really stage PT2B, how often is that you have a tumor that's that large that involves more than 1/2 of one lobe, but does not extend to the midline, does not extend into the fat tissue? Well, I think I staged a PT2B tumor only once or twice in my whole life. I think this hardly, if ever, occurs. And then finally, of course, the most strong proof is there are some clinical studies that also show that substaging of PT2 is not useful. So substaging PT2 is not useful, and you can just omit it. Just say PT2. Then, does tumor volume matter? Well, tumor volume can be measured in several ways. Of course, you can do it very quantitative and really give an estimation in milliliters, and that's quite time consuming. You can also give a maximal diameter of the tumor or a percentage gland involvement. And actually, it doesn't matter which technique you use. Of course, it's very logical that the larger your tumor is, the higher the volume, of course, the worse the outcome. That is what is shown in all these studies. However, if you start to put in these parameters in multivariable analysis and start compensating for PSA, for tumor grade, surgical margin, and PT stage, then tumor volume will have only very limited, if any, clinical relevance. So personally, I don't report it, but I think it's important to discuss this also with your local team. It might be, for instance, that the radiology department is very much interested in your largest diameter, or that they are using it for other purposes, but it only has very little, if any, prognostic value if you compensate it for the other relevant factors. What is important, of course, is extra prostatic extension. It's PT3A. You can diagnose that in several ways. Of course, this tumor when they are growing into the fat tissue, as you can see here, where they are growing around nerves within the fat tissue, and sometimes also when they are really bulging and form a mass just out of the perimeter or the artificial line around the prostate, and that's also extraprostatic extension. Well, extraprostatic extension is mostly easy to diagnose on the lateral and dorsal sides, but more difficult to diagnose on the apex and the anterior side, because there the delineation of the prostate is not that sharp. Of course, you can quantify extraprostatic extension. You can quantify it in several ways. The most easy way is just to give a descriptive term, just say focal or multifocal or extensive. And then the question is, how are these defined? You can also measure the extraprostatic extension. You can do that in a radial way. So how deep does it go into the fat tissue? Or you can do it more in a circumferential way, like this. And actually, it doesn't really matter what technique you use. They all have independent relevance. So here you can see what happens if you grade it or stage it as focal or non-focal. You can see, obviously, that the non-focals are doing worse. And this is where they looked at minimal radial distance. So how far did the tumor go into the fat tissue? Of course, the further it goes, the worse is the outcome. So quantifying extraprostatic extension is informative. Then what technique should we use then? As I told you, there are several ways how you can quantify extraprostatic extension. So what's the optimal or most practical way? Well, this was a nice, quite old study that looked at several ways of quantifying extraprostatic extension. And what is important, what they found is that actually the unilateral extraprostension and the bilateral extraprostension did not have prognostic significance. Also, unifocal, multifocal did not have prognostic significance. And actually what they found is that all these ways of quantifying extraprostatic extension, whether you use focal or established, you can even use it on different criteria, using a radial distance or more a circumferential length, they are all associated with outcome. So extraprostatic extension is strongly associated with clinical outcome. Unfortunately, there is not a consensus how you should report this. Of course, you can measure the radial distance or the circumferential distance, but this is quite time-consuming. And the most important is that you just discuss with your local urologist, what's the preferred and most practical way of doing so. So we did not talk about the location of extraprostatic extension yet. The location of extraprostatic extension does not have prognostic value, but mostly it's important for the urologist to know where the extraprostatic extension was. And that's mostly for the quality control. And when I'm talking later about surgical margins and nerve-sparing surgery, I will come back to that. So location, I would really advise to mention that in your pathology report. So then a few words on bladder neck invasion. So when I was a resident, the WHO said that bladder neck invasion was PT4 tumor. That was the 6th edition. Now we are in the 8th edition. And if you look now at the TNM, bladder neck invasion is just classified as PT3A and not as PT4 anymore. This is just one example of a study from Johns Hopkins, and they show here if you have bladder neck invasion, your outcome is mostly similar as patients with extraprostatic invasion, and definitely not worse than patients that have seminal vesicle invasion. So bladder neck invasion just classifies T3A and not as T4 anymore. Seminal and vesicle invasion, and in most studies, it's really an independent adverse factor. You encounter it, in about 5%, I think, of radical prostatectomies. You can call seminal vesicle invasion if the tumor invades the muscular wall. That's important. So tumor that is growing into the extraprostatic fat tissue around the seminal vesicles, but not in a muscular wall, that's not seminal vesicle invasion. So you need to invade the muscular wall. One question is also, where does the seminal vesicle start and end? And so it starts with the ejaculatory ducts, and then it slightly goes in the seminal vesicles. So where should I start considering it as a seminal vesicle? And that would be only the extraprostatic part. So the intraprostatic part of the seminal vesicle or the ejaculatory ducts, you should not consider that as a PT3B or a seminal vesicle invasions. And there's one study really looking at those, and those patients also really seem to have a better outcome than the ones with true seminal vesicle invasion. Tumors can invade in several ways in the seminal vesicles, and here this is a very nice diagram. So they can extend from the ejaculatory ducts right up to in the seminal vesicles, and they can go from the prostate directly in the seminal vesicles, first go into the fat tissue and then in the seminal vesicles, or, and that's the least common, discontinuously involve the seminal vesicles. Well, of course, the most common you encounter are the direct extensions of the tumor in the seminal vesicles. That's 90–95% maybe of all the seminal vesicle invasions, and the discontinuous invasion, so that are small metastases of tumors in the seminal vesicles. You will encounter that probably in 5 to 10% of patients. And they tend to have maybe even a little bit better outcome than the ones that have a direct continuous invasion. But we classify them as PT3B and definitely do not classify those patients as PM1. So you should know this can occur, discontinuous involvement of the seminal vesicles, also classified as T3B. Lymphovascular invasion can be found in some radical prostatectomies. Usually it's a rare event, and I think in less than 5% after radical prostatectomies. Several studies have looked on the clinical relevance of that, and yeah, most of them find that if you have lymphovascular invasion, that's associated with adverse outcome. But if you again start to compensate for other factors such as PSA, tumor grade, tumor stage, surgical margin, the question is really whether lymphovascular invasion still is an independent prognostic value factor. So probably it will have no or only very limited prognostic value when you compensate for the other factors. The same is true for perineural invasion. Of course, that is very common, perineural invasion. Again, there it is associated with more aggressive disease and more often with higher volume tumors, positive surgical margins. But if you put everything what's relevant in regression analysis, perineural growth doesn't have any or only very limited prognostic value. Then finally, the surgical margin stage, this assessment. Well, the ICCR recommends to put in several items on surgical margin assessment. Of course, is the surgical margin positive or negative? Where is the location of the positive margin? The type of positive margin, I will come back to that. Extent and the Gleason pattern of the margin. Well, a positive surgical margin is defined as that the tumor should be touching the ink. So if there is still a rim of 0.5 millimeter between the ink and the tumor, the surgical margin is just a negative, it's free. And you don't have to say it's close to the margin or the margin is negative, but it's only negative for less than 1 millimeter. That doesn't have any clinical relevance, so don't do that. If it touched the ink, call it positive. It doesn't touch the ink, call it negative. Location of the positive margin, it's mostly important for the urologist. They want to know where they got too close to the prostate or through the tumor. I will come back to that later again. So it's important for them, they know, and they often ask for that, where the margin were positive. Some studies have also looked at the location of the positive surgical margin, and it might that the posterolateral surgical margins have some adverse impact on if you have a positive surgical margin. Sometimes you can see that the urologist has cut into the prostate. That's called a capsular incision. That's also what we report mainly as a feedback to the urologist, and it tends that these patients also have a slightly increased risk of tumor recurrence. Of course, you can go into detail if you're calling a positive surgical margin. You can measure the extent, so what's the cumulative extent that the tumor reaches into the margin. And we know that the more tumor is going into the margin, the higher the chance of biochemical recurrence. There was one study that said that there was an 8% higher chance of recurrence per millimeter positive surgical margin. What's also important to realize that when you have just a minimally positive surgical margin, and then less than 3 millimeter or less than 1 millimeter, actually those patients do not have higher rates of biochemical recurrence. So less than 3 millimeters, some studies use 1 millimeter. The impact on biochemical recurrence is nothing. So these patients will not have too much much impact if your margin is only minimally positive. You can also look at the Gleason pattern that's into the margin. I should explain that. So if your entire tumor would be a Gleason score of 3 + 4 or 7, it means you have a mixture of Gleason pattern 3 and, for instance, 20% pattern 4. But this pattern 4 often is not everywhere around and evenly dispersed within the tumor, but it can be present more common in some places and less in other places. So you can see what kind of tumor glands are reaching into the ink. So if you have patients with a Gleason score 7 and look what is the Gleason pattern or the Gleason score into the positive surgical margin, you can see that the patients that also have Gleason score 7 into the margin have a much worse outcome than the Gleason score 7 patients that only have Gleason pattern 3 in the margin. Actually, their outcome is quite good and almost as good as patients without positive margin. So the Gleason pattern in the margin is really an independent prognostic value factor for biochemical recurrence. So with all the attention to cribriform pattern last decade, we've also looked whether presence of cribriform pattern in surgical margin makes a difference. Well, this is actually quite a rare finding, and we did not find that this has any clinical impact. So you should report whether cribriform pattern is present in a radical prostatectomy, but you do not have to report whether it also reaches into the margin. So what's urologists doing with this information on the margin status? Well, most important is presence of positive surgical margins is mostly prognostically. If you have a positive surgical margin, and specifically if it is more than 3 millimeters, then urologists know there's a higher chance that the tumor will recur. Sometimes they will give adjuvant therapy. So if you have a vastly positive surgical margin, often also combined with extra prostatic extension, and they might consider giving immediate radiotherapy. But it's always also important for them as quality assessment. And now I will go a little bit more into nerve-sparing surgery. So if a urologist is planning a surgery, he can remove the prostate, but can also decide, should I leave the nerve bundles within the patient, or should I also remove the nerve bundles? If you remove the nerve bundles, there is a higher chance of incontinence and erectile dysfunction, but there is less chance of positive surgical margin. However, if you leave the nerve bundles within the patient, there's less chance of functional outcome after operation, but you have a higher chance of positive surgical margin. So that's what they wait before every operation. I will explain this in more detail. So let's go back to this radical prostatectomy. Here you see the prostate, here you can see fat tissue, and here as well. So the neurovascular bundles, or the nerve bundles that are aside of the prostate at the posterolateral side, that's not just one thick nerve bundle, but it's more a complex of small nerve fibers that are situated like this. Urologists then can decide whether he's doing nerve-sparing surgery in several ways. I'll show this here. So this was the first picture. So they can remove only the prostate and leave all the tissue inside the patient. And that's called nerve-sparing surgery. You can also decide to remove the neurovascular bundle, and that's called non-nerve sparing surgery or minimal nerve sparing surgery. So what is he doing when he's doing nerve sparing surgery? He's really cutting into the so-called capsule of the prostate and leaves all the fat tissue with the nerve fibers within the patient. Extreme alternative is that urologist removes all the nerve fibers that are next to the prostate. That's called non-nerve sparing surgery or minimal nerve sparing surgery here. And you can also do something in between, and that's usually called partial nerve sparing. So you leave some of the nerve, you remove some of the nerve fibers and leave other ones intact. So that's called nerve sparing surgery, non-nerve sparing surgery, partial nerve sparing surgery. And you should realize a prostate, of course, has two sides, two neurovascular bundles. So you can also decide to do nerve sparing on one side and non-nerve sparing on the other one, or doing a complete nerve sparing on the left side and partial nerve sparing on the right side. So there's lots of variability here. So what's the relevance of this? Well, if you look at the extent of nerve sparing surgery, it really has impact on post-operative urinary incontinence. So if you do bilateral nerve sparing surgery, so that means on both sides you leave the neurovascular bundles intact within the patient, and you will have about 10% 60% of incontinence after the operation. The other way around, if you remove the entire neurovascular bundles on both sides, the chance that a patient will be incontinent after operation will be around 60%. Then, of course, you have unilateral, and you could even have the partial ones that are all in between. So that's the impact on urinary incontinence. And if you go to erectile dysfunction, it also has an important impact. So if you do bilateral nerve-sparing surgery, it's said that 30% of the patients will only have erectile dysfunction if you do not do nerve-sparing surgery, so remove all the nerve tissue. About 70% will have erectile dysfunction. But I will come back to these numbers later. So the degree, the level of nerve-sparing surgery has impact on urinary incontinence and erectile dysfunction after the operation. That's the most important thing to know. But okay, how do we measure this erectile dysfunction? Again, if you see the literature, often these are studies from single center studies. They might even tend to only be published when they have a very positive effect. So how should you really measure erectile dysfunction? Again, I come back to a study in the Netherlands that was done on all the participating hospitals. So I think it's gives a good idea what's going on in real general practice. And what you see here is that they use the so-called EPIC 26 survey for getting information on erectile dysfunction. There are more of these surveys, but they use this one. And what the patients get then, they have several questions. And if they have the maximal answer to all of these questions, they don't have erectile dysfunction, and then the scores goes down. So the maximum score you can have here is 100. Interestingly, if you look at the patients that were operated in this time period, before operations, this was not 100. So that means that many patients that are operated for for prostate cancer do not have optimal erectile function. About only 60% of patients have normal erectile function before operation, and after operation it gets worse. But then again, these are just continuous gradual scores, but it doesn't say everything what the patient is really finding out. So what they also asked to the patients is, okay, you have the score, but do you have erections that are firm enough for sexual intercourse? And so that would be fully functional. And we were actually really surprised, because after 1 and 2 years, only about 10% of the men that had undergone radical prostatectomy, and all these patients had normal erectile function before operation, but only 10% after operation had normal erections that were firm enough for sexual intercourse. And this is really low. So it's much lower than, for instance, the 30 or 60% that I just showed you a few minutes ago. So you should really be aware, if you look at these studies, what is really the outcome measure? Are they using just a gradual scale, or how do they define this? But this is really a strong definition, and you can see most patients, about 90% of patients after operation, will not be able to have sexual intercourse anymore. And that's lower than would be expected from the previous literature. But it also shows that there might be, we could also raise these quite bad figures. So there is also an opportunity. So for the urologist, always finding a balance about maximal nerve-sparing surgery that saves urinary incontinence and erectile dysfunction, but not increase positive surgical margins, and having higher risk of biochemical recurrence and adjuvant therapy. So how does the urologist decide on whether he's doing nerve-sparing surgery? Well, actually, I was surprised to find out this is actually quite subjective. They don't use a nomogram or a specific algorithm, but they just subjectively include information on biopsy tumor grade, tumor volume, MRI findings, and clinical impression during operation. Actually, what the idea behind that is, if they think there's quite a chance of the tumor to grow into the extraprostatic fat tissue in the neighborhood of the neurovascular bundles, they want to cut out the tumor. And that's the idea. So it's about the prediction of extraprostatic extension in the area of the neurovascular bundles. That's what they are trying to do. But of course, it's difficult, even when you take all these information into account. So can intraoperative assessment of the surgical margins help out? And that is a very nice study from the Martini Clinic in Germany, and they did more than 10,000 radical prostatectomies, and they did a very systematic way of assessing the surgical margins, and that's called NeuroSafe now. Actually, it's a technique that was developed about 10 years ago in the Martini Clinic, but now in Europe, there are more and more clinics that are starting offering this technique to the patients, and I will try to explain it to you how it works. So the urologist operates the prostate and only gets the prostate out, doing a full nerve-sparing surgery on both sides, so leaving all the neurovascular tissue within the patient. When the prostate goes out, the urologist cuts the prostate at the margin where it's adjacent to the neurovascular bundles that are still into the patient, and send both sides to the pathology lab. So during operation, then pathologist cut this in deeper levels, and then is doing frozen sections. So that means if he cuts on both sides the posterolateral surface of the prostate, that would result in about 20 frozen sections of one prostate, about 8 to 10 sections per side. Then, if the pathologist reports there's no, the surgical margins are negative, then there is no neurovascular bundle resection. And if the tumor is growing into the surgical margins here, then urologist goes back during the operation and also remove the neurovascular bundles. So that's actually how this NeuroSafe technique works. So in Hamburg, they did many patients, more than 5,000 they included in this study. About 25 had a positive surgical margin. But if they looked and compared their outcome with a historical control cohort, they found that they were able to more often perform nerve-sparing surgery, from 81 to 97% of the patients. What's interesting is that the number of positive surgical margins decreased. Actually, that's really interesting, because you might on beforehand expect, okay, if you perform more often nerve-sparing surgery, probably you will also cut more often, more frequently through a tumor. But actually, that's not the case. And so the positive surgical margin rate decreases also by doing this. And what's important, they also found that the patients that underwent this NeuroSafe technique did not have higher chance of biochemical recurrence. Some other sites have also reported on this. So in the UK, they have looked at 120 of these patients with NeuroSafe. They found more or less the same findings, but also were able to look at functional outcomes. And they said, okay, the rates of urinary incontinence decreased from 29% to 14%. And in their series, but we already discussed about the definitions of erectile dysfunction, it decreased from 49 to 23%. So it's not only leading to more nerve-sparing surgery and less positive surgical margin, but probably also to better functional outcome. We also looked at this, so we are doing this now since September 2018 here in the Netherlands, and we also found more or less similar findings. If you do NeuroSafe and you control for all the other clinical relevant factors, you have almost 4 times higher chance of doing unilateral nerve-sparing surgery and more than 5 times more chance of bilateral nerve-sparing surgery. So this technique really enables us to perform more often, far more frequent nerve-sparing surgery, and specifically in patients that have more aggressive tumors. So this NeuroSafe, more nerve-sparing surgery, but less and less positive surgical margins. Biochemical recurrence rates do not go up. There are some indications for better functional outcomes, but the other side is it's very labor intensive for the pathology department, and we still need randomized clinical trials that really show that the functional outcomes of these patients is better after doing NeuroSafe. Of course, I will go a little bit at what this means for the pathology department. So in many of these studies that were done, all the patients had undergone NeuroSafe, but you can imagine that you do not have to offer this to all those patients. So if you have a man of 70 and he does not have erections anymore, you might ask the questions, is it really worth also doing NeuroSafe, because saving of erectile function is not important in this patient anymore. So it seems to be most important for patients that are still sexually active and find this very important. And you can also imagine that if your biopsy and MRI says there's only tumor on the right side, but no tumor on the left side, maybe just do complete nerve sparing surgery on the left side and only do NeuroSafe on the right. So you might individualize this. So what does it take? So these are data from Martini Clinic. So they took 8 to 20 frozen sections per patients, and there were 3 to 5 technicians there working on 2 to 4 cryostats at the same time. And it took 20 minutes pathology time and about 30 to 40 minutes of additional operation time. So the procedure took 30-40 minutes, while the urologist is not just drinking coffee during this time, but he's making the anastomosis of the urethra and the bladder neck. He's doing a pelvic lymph node dissection, so this time is not completely wasted. While the NeuroSafe technique, of course, it takes lots of time, it's really labor intensive. Are there also alternative techniques? Well, several studies have reported on frozen section evaluation of surgical margins, but not really in a standardized way. So often they just, quite subjectively send in some fat tissue, but it's very difficult to draw more general conclusions about that. And the outcome of those studies, was very variable. So this might be still a little bit old-fashioned technique. Are there not newer techniques that can help us, that are easier to perform? And I'm happy to say that there are. So maybe some of you are familiar with one of these medical devices. And actually what these devices do, they can give you an intraoperative microscopic picture of a tissue piece. So let me explain in more detail. So if you would do a NeuroSafe and you would cut 10 up to 20 slices, normally you would freeze those slices and make frozen sections of that. When you use one of these techniques, you cut the slices, but do not freeze them, but you put them in a kind of staining solution for 1 or 2 minutes. And then the staining solution contains fluorescent molecules that bind to epithelial cells and other structures. Then you put this fresh piece of tissue that was put into this fluorescent dyes on a kind of confocal laser scanning microscope, and that images the surface of this tissue piece. And of course, you know that this fluorescent images would give a fluorescent picture, but then there is an algorithm that just translates this fluorescent picture to a H&E-like staining. So you will get finally a result like this. So there are, I think, at least 2 CE accredited systems on the market for intraoperative assessment of fresh tissues. And this might be an alternative in the future for NeuroSafe. So I do not have personally experience with that, but I know there are some institutes that are employing this kind of techniques as an alternative for intraoperative frozen sections. So that might be the way to go in the future. And for instance, this publication, very recent actually, is from, I think, an Italian group that also showed that this is really feasible as an alternative for NeuroSafe, but only in a few patients. So there are not really outcome data yet on how effective this is, or what's the false positive or negative rate. So NeuroSafe, a detailed pathological evaluation of surgical margins and extraprostatic extension are important for surgical quality control and prognosis. Remember, for urologists, it's really finding a balance between maximal nerve-sparing surgery and oncological outcome, and intraoperative frozen section assessment, but maybe also one of these newer confocal laser scanning microscopy might reduce post-operative complications. But again, clinical trials are necessary to see what's the really clinical impact of these labor-intensive techniques. Just to wrap up, what I showed you today is mostly also what the ICCR is reporting. You can find this on their website, and this was also summarized by Kench in Verkov's archives. And this gives a very good overview on all the required and recommended issues to be included in pathology reports. And this is just the template of it. It also gets quite a few notes with it, and that explains why you should do this or what is the scientific relevance of that. So then finally, what is the critical relevance of that? And so that's always, to me, quite depressive actually. And so we do all this effort for the nice grading and calling in tertiary patterns and cribriform patterns and measure positive surgical margins and radial distance and extraprostatic extension. And what's the urologist doing? Just follow up. And when the PSA is rising, they are going into action. So that might be a little bit depressive, but at this, most of the outcome, what we do is prognostic and will not immediately result to alter treatment decisions. It might sometimes be the case if you have, for instance, very extensive positive surgical margins or extensive extraprostatic extension. So then the urologist might decide to give immediate radiotherapy, but usually they will just measure PSA after operation. And when it is rising, then they consider that as biochemical recurrence, and then they go for adjuvant treatment. What it is very important for, I told you, was as a quality control assessment, as to be able to compare results between different institutes and to improve outcome if you have these data. And it's also a very important issue if you're looking at local quality improvement. So what do we mean with that? Well, what you can see now here in Europe, that more and more centers are not doing 50 or 100 radicals a year, but they just centralize their operations in one center. So in earlier days, there were 50 centers, each doing 50 radicals. And maybe in the future in the Netherlands, there are only 3, each of them doing 800 radicals. And if you have that much patients, you can really start working on local quality improvement. And this is just a very nice example. This is a study and that showed what happened in the London area when they started centralizing radical prostatectomies. So when you are doing lots of radical prostatectomies, you can really on a monthly basis just look on, okay, what was the outcome? How often did I do nerve sparing surgery? How often did I have positive surgical margins? And when the surgeons do this on a monthly basis, they can see how am I performing in relation to my colleagues. And in that way, people can learn from each other and just look, so what's this colleague doing that having that low rate of positive surgical margin? You can look with this colleague and that way, increase or operate better yourself. So what they were doing this, they was doing this every month. And what you could see actually is that their functional outcome after radical prostatectomies really was better when they started including this local quality improvement program. And of course, pathologists played a very important role by giving this feedback and in this improvement. So in that sense, it might really help you locally by doing this in a regular way. I think this was the last slide of my presentation, and I would be very happy to answer any questions.
Fabulous, Arno. That was a real romp through the whole process. We've got lots of questions. I haven't got much time. We're slightly over, but let me just start at the top. So the first question I can find is, this is interesting. Is the planes for various nerve-sparing procedure a distinct pathological feature?
Yeah, well, actually, our urologists do not tend to inform us about this. So it's just I just want to share with you that you can see this and what it means. So if you start notifying us, you can already imagine, okay, this was completely nerve sparing or completely not, or partial. So you do not have to report it yourself back to the urologist because he or she should know what he did. But it's just that you are aware what this means and why they are doing this actually. So you do not have to put this in your report yourself.
Yeah. The next question is, what grade would you grade IDC?
Yeah, it's determined that you should grade it based on the underlying architecture. So that would be mostly, it is just cribriform, the intraductal carcinoma. So in most cases, I would give the Gleason pattern 4. When it is solid, I would give the Gleason pattern 5.
How easy or difficult to make out the margin on and EPE on frozen section?
Yeah, so on frozen section, there is a learning curve. So when you start doing this neurosafe, it takes you some time to get used to the pictures and also for the technicians to cut the tissues just in the right plane, that you have the ink and the tumor just in the right way. But if you have that, actually it's quite good. So we did some studies on that, and you can really see that the false positive and false negative rates are quite low. So you can really appreciate this on frozen sections actually.
Does microscopic versus macroscopic EPE have any bearing on clinical outcome?
Yeah, that's an interesting question. I'm not aware of any macroscopic EPE studies, but of course, macroscopic, you would assume that these are really large volumes of tumor growing out of the prostate. And then you can imagine that these patients, of course, have much worse outcome as well.
This is a great question. Do you count and include in the report the numbers of nerve trunks in periprostatic fatty tissue? And if so, how?
Well, a very simple answer is no. I don't count any nerve fibers. No, just to be serious. So that does not have any clinical impact.
To correctly evaluate bladder neck invasion, is it necessary that the surgeon send it separately?
No, I don't think so. So, yeah, for instance, you can call it if you have, the base of the prostate, and you can really see that the smooth muscles going in that look more like the trusor muscles and not more like the normal prostate, and specifically if the tumor also grows there into the surgical margin, that's what I call a bladder neck invasion. If the urologist really sends in a part of the bladder separately and it would go into there, then I can discuss with him, okay, should we consider this really bladder invasion, so T4, or still bladder neck T3A?
Another question was, how do you report the Gleason pattern in a damaged surgical margin, where there's diathermy or something like that? It's quite difficult when there's smearing of the gland.
Yeah, that's a great question, because that happens in real life. And then we just look at the tumor that is still accessible, or maybe if it is just 1 millimeter away of the margin. But I'm not going to try to grade anything that's completely damaged.
Okay, this is regarding neurosafe. I would imagine it is more difficult to assess the surgical margin in the subsequently resected tissue, or am I wrong? For instance, is there a extra prostatic extension and positive surgical margin in a frozen section?
Yeah, I will just read it myself, I'm sorry. Yeah, so what happens actually, so if the neurosafe is positive, then they will do an additional resection of the neurovascular bundles. It's important to communicate this, because if you would say, okay, the tumor goes in a neurosafe surgical margin, but only at one place for an area of 2 millimeters, then urologists can try to reallocate this area and only do a partial dissection in this area. So it doesn't mean that the secondary resection is always the entire bundle. And actually, it's not that difficult, because you just get a chunk of fat tissue, can be small or larger, and you just ink it. And usually they mark the site that's close to the prostate and what is the real definite surgical margins. And in practice, that is not difficult to assess. So you can always evaluate in a good way the real surgical margin then.
How do you report the margin measurements if it's multifocal?
I would just say that there are depends a little bit how we would define multifocal. So if there are two positive surgical margins just 4 millimeters away from each other, I would just add them up and just say, okay, that's cumulative positive surgical margin of 1 and 1 is 2 millimeters.
I think the answer
so
is
mostly
that we don't know. I don't think there are many studies that are going to be splitting into, if you have a 2 millimeter here and a 2 millimeter there, what's the significance of having a 4 millimeters over 2 areas or 4 millimeters over 1 area? I don't think that those studies have been done to actually know. So the answer to that is we probably don't know, but we just add them together. We're running out of time, I think. Okay. One question is, frozen sections is talking about neurosafe, presumably 8 to 20 or 20. Which?
Yeah, that's a good question. I'm sorry, I didn't make that clear. So it would be about 8 up to 10 slices per side. So if they only would do neurosafe on the left side but not on the right, it only would be 8 up to 10 slices for the left side. But if they would do a bilateral neurosafe, so left and right, then it will go up to 16 up to 20. So sorry, that's what was meant there.
And that really depends on the size of the prostate. So when you pick them up and they're like 90 grams, your heart drops as the prospect of doing more frozen sections. So you hope you have young men having their radical prostatectomies because they're smaller glands. I think that's possibly so one question was a Gleason pattern at the margin or the score at the margin?
Yeah, I don't think it really matters to do if you say there is pattern 4 on the margin or only pattern 3 or Gleason score. I just myself only say Gleason score because that's also what's used in a radical prostatectomy, but it doesn't matter if you say 3 + 3 is 6 or only pattern 3.
I think there are some more questions, but biobanking. Do you do any fresh sampling biobanking for radical prostatectomies? Could this make difficulties in assessing extra prostatic extension or surgical margins?
That's a good question. So this really depends on the institute you're working. So if you're working in an institute where there's a lot of translational and molecular research, probably you will sample more for the biobank. One difficulty in radical prostatectomies is that you cannot really delineate the tumor at growing often. So you do not know where to sample tissue for your biobank. Of course, you can have a high rate of tumor within your biobanking issues if you have information, for instance, where the biopsy was positive or where the MRI showed the tumor. But if you're not informed at all, you could, for instance, include one entire transverse slice for biobanking. But of course, you can miss some information over there. But this really depends on what the goal is of the biobanking itself.
Do you actually do it in your center?
At this moment, not. But this is because we are mostly interested now in neurosafe assessment, and that's the reason why we do not do biobanking. But this might really differ in time period and by institute.
But the neurosafe actually offers you an opportunity to do biobanking because you've actually done a frozen section.
If you do neurosafe, if you're neurosafe, then biobanking it's easier because then immediately you have your reference H&E. You can just see, okay, this is the slide that contains tumor, and I have it frozen anyway, so I will put this in the biobank. Yeah, in that sense, it is much easier. Okay, well, I think that's probably all the time we have. Thank you very much, Arno, for giving another lecture for us. And it was great to go through all those things and see the evidence behind them rather than just doing it for no apparent reason. Brilliant. Thank you very much, Arno. Okay, happy to do so. Have a nice evening. Thanks.